I'd like to thank very much my good friend Bruce Shields. He was my mentor at Yale, and he always will be one of the most important glaucoma specialists that I ever met. And this is not just my opinion; it's all over the world that you go. Whenever you say that you were a former Shields Fellow, the door starts open. So I have to thank you very much for that. It was a pleasure staying with you at Yale. And I'd like to start this conversation, and thank you very much to accept this conversation, this interview. And I'd like to start this conversation with the reason that I tried to stay with you at first at Duke, and then you moved to Yale. I first applied for Duke, and then you changed to Yale, is that I learned glaucoma by reading your books. There are two main books in glaucoma. One's the big three volume books and your textbook of glaucoma. And the textbook of glaucoma was the most important source for me, and still are, to enjoy this very challenging specialty in ophthalmology. And I know some part of the history of how you start with this book, and I'd love to have you sharing for us the history, how it starts and how it was important for your life. I saw that in some books also, you telling how it was important. And I appreciate very much you start this interview by asking the history of your textbook of glaucoma.
Thank you, Augusto. Those are very kind words. And first of all, I have to apologize. I don't know why I'm green. I've never seen this before, but we can't seem to get rid of the green. So I guess we'll just have to live with that. Your words were very kind, although I think the day has come when I take pride in saying, well, Dr. Augusto Paternoss was one of my fellows. That's one of the claim to fame. So, and I'm very proud of Augusto for all that he has accomplished, and Maria and all those that I was privileged to work with from Brazil. So the textbook, Augusto, really started when I came back from my fellowship at Mass Eye and Ear. I was supposed to be the glaucoma expert at Duke. And so I began giving a series of lectures once a week. And I put together a little outline, a little printed outline for each lecture. And after a year or so of that, I was surprised when some of the residents said, you know, we've been saving your outlines and we keep them in a file like a little book. And they said, you know, we think that you ought to publish this outline. So I got to thinking about that. I wasn't doing much meaningful research at the time, so I thought, well, maybe this is something I can do. So I tried to put the outlines in a little more formal manner and submitted that to a number of publishing companies and was summarily rejected by every single one. Nobody was interested. And I was about ready to give up. I figured, well, okay, I guess that's not going to work. So I kind of forgot about it until one day I got a call from this editor at Williams and Wilkins. That was a publishing company back then. And they said, you know, we decided we would like to take a chance on publishing your book. And I found out later that my very dear friend Harry Quigley, who everybody knows, told me many years later that he was one of the reviewers who recommended that they publish it. So I owe Harry quite a debt. Anyway, the book was published, and initially the idea was it was in an outline form, and the name of the first edition was a study guide for glaucoma. It was pretty modest, and much to my surprise, some people seemed to like it. And so after the usual 5 years or so, the publisher said, you know, we'd like to do another, but we want to kind of elevate it to a more of a textbook level. So I expanded the content, and we added pictures and changed the name of the book to Textbook of Glaucoma. And that was the second edition. And now, today, the seventh edition will be coming out this fall. And but Augusto, one of the things that I'm very proud of is that 2 editions have been translated into Portuguese. That second edition came out in Portuguese in 1989. And then, as you well know, the 5th edition of the textbook came out in 2008. And I was very proud that you were one of the 3 translators of that edition. So that makes it very, very special to me. But maybe we'll have to talk about another Portuguese translation before too much longer. But that's the story.
Okay, great. But I understand that it was translated to many languages. I think it was one of the book that was translated to more languages that in glaucoma that ever was published. I remember your bookshelf, all the different translations to your book, and I was amazed on that. And I was looking a lot with everything that you write, because you know very well how to write. I remember how I was ashamed I was ashamed to send you something that I was in charge to write, because it comes with a lot of reds. And I remember the history that you told me about the first paper that I sent it to you, and it was, everything was red. You're correct, that almost everything.
Right.
You told me that the story that red is not bad. Remember that one?
I do indeed. I'll tell the others the story because it's humorous and also very humbling. But I did my glaucoma fellowship at Mass Eye and Ear with Dr. Morton Grant and Dr. Paul Chandler and Grant. And Dr. Grant was a very, very good writer. And so when I submitted my first first draft of the first paper, I did so with a certain amount of fear and anticipation. And a week or 2 passed, and finally he asked me to come into his office, and he had the paper in his hand, and I glanced at the paper and I saw there was no red at all. And I thought, oh my goodness, I must be so good that he couldn't find anything wrong with my paper. But, and he was a very kind person, and he kind of shook his head. He said, you know, this paper was so bad, I didn't even know where to start. So why don't you just take it and try all over again? So that was a wake-up call for me. So I tried it again, and the next time it was covered in red, and so I figured I was making progress.
But, red's not bad.
That's why red is not so bad.
Yeah, I learned that, and I used to say that now. There's something, you have a lot of different books. I remember one that you have, what, 100 history of glaucoma, 100 years of glaucoma, talking about the history of glaucoma. I have this one. I have everything. Um, but there's one that's very special for me. The one that was not a textbook of medicine is the gift of sight, that you have some, you give some impressions that you have with your patients. I would like you to talk a little bit about this book, and maybe talk about some specific patients that you think that it gives you, how do I say, it make you wonder, how is it to be a good doctor, and how is it to the the feeling that you have to treat them.
So for those of you who aren't familiar with this, I did uh, write a book called Gifts of Sight, which, as Augusto said, is not a scientific book. Um, it's actually a book about patients that I was privileged to care for when I was at Duke and then at Yale. And the origin of that book actually is in the third chapter of the book about a lady. I called her Alice Fleming. I changed the name of most of the people for their privacy. But that chapter was entitled Alice Fleming. And she was an elderly lady, probably in her early 90s. And this was back when I was just starting out. I was probably in my 30s at the time, young enough to be her grandson, but she insisted that I call her Alice. And of course, she had glaucoma, but she also had cataract surgery, and she had macular degeneration. And she had lost her husband and was now living in a retirement home. And one day she was brought in for her routine exam. And as I usually do, I said, "How are you?" And she said, in her usual cheerful way, "Oh, how could I not be wonderful on such a beautiful day as this?" And that kind of caused me to pause because, frankly, I hadn't seen anything beautiful about the day. I've been worried about all kinds of things, and she kind of picked up on that and went ahead to describe what it was like coming over from her retirement home in a van that a person from the home was driving. She said, "Oh, it was a lovely day." She said, the sun was so warm coming down through the pine trees, the, but, but the breeze was cool. The birds were singing. I could smell flowers. I think the wisteria was hanging down from the trees. Just a lovely day. And that was when it dawned on me that she came down the very same road that I came down to go to work each day. And I hadn't seen any of that. I had not noticed the warmth of the sun or the coolness of the breeze. I had not heard the birds or smelled the flowers. And I hadn't seen a thing. And she had seen everything. And the irony of that is that, as you can probably guess by now, she was legally blind. So here was a person who was blind telling me all the beauty there was around me to see. And that was what caused me to begin to understand that there are people in this world who have a kind of a light inside them that overcomes whatever their darkness could be, whether they're blind or deaf or crippled or whatever it is. they have such a cheerfulness about them that they can make a good life no matter what their circumstance. And the more I thought about it, the more I realized I had a lot of patients like that. And each one of them had their own story. So I began writing these stories about these patients. And the title of the book, Gifts of Sight, doesn't refer to the gift that I gave them of being able to see. It was the gift they gave me of the insight to understand better how to live a good life, no matter what your circumstances may be. So she was the one that kind of got me started. So I wrote about half the book in retrospect of patients I remembered at Duke. But then I got to a point where I ran out of stories. I maybe hit a writer's block, and I thought, gee, what? So I just set it away, put it away. And it wasn't too long after that that I got a call from the dean at Yale saying they wanted me to come up, interview, and of course, eventually I accepted the chair at Yale. And that was when it kind of dawned on me, I had only lived half the story. The other half was still ahead of me at Yale. So the second half of the book is patients that I was privileged to care for at Yale. And that half was written more prospectively because I was conscious of the fact that I was going to be writing about it. And in fact, I even told the patients that I'd like to write this about you. Are you okay with that? And Augusto, one of them you may remember, there's a chapter in the book called Blessing. There was a young man of African heritage, I think he was from Kenya, blessing offer. And he had congenital glaucoma and was blind in one eye, totally blind, and had just enough vision to get around in the other eye. And his parents sent him all by himself. He was like around 5 or 6 years old when he was sent to New Haven, Connecticut, in order to get better eye care at Yale because he had an uncle who lived there. So one of our other glaucoma specialists at Yale took care of him at first. And like all young boys, he wanted to be out playing. And he would go out and play ball, play basketball with his friends. But one day he got hit in his good eye and got a hemorrhage and damage to the eye and a very high pressure from the hyphema, and basically not only lost the vision in that eye, but the eye was very painful. And that was when I saw him for the first time. And I'll never forget walking into the room, a room that you were in many times, Augusto, there at Yale. And here this little guy was in this chair. He looked so small in this big examination chair. And his tears were pouring down his cheeks. He was having pain. And I thought, I had never seen anything so pitiful in my life. In fact, I thought his name was Blessing. And I thought, that's a cruel joke because his life was anything but a blessing at that time. But we operated on him and got his pressure under control and relieved his pain, but we're not able to bring back his sight. So he went back to my colleague who was taking care of him, and I didn't see Blessing again for another probably 5 years or more. And the next time I saw him was when I saw his name in the newspaper announcing this concert that was being given at a local venue. So I went to it with some friends from the Eye Center, and I was expecting to see this little pitiful guy walk out on the stage. But what I saw was this young, handsome guy with confidence who sat down at his keyboard and played these songs that he had written himself and sang and played. And it was just amazing, the transition in him. And he went on to give more concerts over the next few years. And finally, he got an international award and played at the Kennedy Center in Washington, D.C. in a special program. And he has since been on television. He's recorded several CDs, and he's really got a good career going for him. And he and I kept up, and we would have dinner together every now and then. And one day I asked him, I said, Blessing, what was it that gave you took to go from being such a pitiful situation to being so successful? And he said something that I'll never forget, and it may be one of the most important lessons I ever learned. He said, he said, sometimes things that seem so bad can actually be a blessing in disguise. He said, for example, when I still had my sight, I wanted to be outside playing. I didn't want to be inside learning my piano lessons and composing music. But when I lost my sight, I couldn't go outside anymore. So I started learning to play the piano and writing music and singing. And he said, if it hadn't been for my blindness, I would never be where I am today. So he said, for all of us, we may have things in our life that seem really bad, but if we look at them in the right way, they can actually be very good. So that was a lesson. So every chapter of this book is a lesson that I learned from my patient. And that's the gifts of sight.
Yes, and I recommend for everybody. It's you can buy this on the Amazon. It's I don't know if it's just I have it in the how you call this
The Kindle.
Kindle. Yeah, I bought it by Kindle.
It's available in hardback and paperback, but also it's available in Kindle. You can get any one of the three on Amazon or some of the other book providers.
Well, I recommend it. It begins with the history of your textbook of glaucoma too.
Yeah.
I'm gonna pass to my colleagues to make some questions, but start with one story that I don't know if you remember, because it was a long time ago, but it was very interesting to introduce our next discussion. You organized at Yale a meeting on technology and imaging of the optic nerve. You invite Professor Schumann and Professor Spaeth. It was the beginning of OCT, and HRT was it was all about imaging and imaging technology. I remember that I was amazed with the new technology. Everybody was there because of the technology. And the last lecture was a lecture with Professor Spaeth, and he put one of his draw and saying that I don't believe in anything about this. The most important thing, there's no use for that. The most important thing is the drawing of the optic nerve. And you were beside me, and you told me I have to fix it. And you will go up there and tell the audience, he's completely right. There's nothing better than his drawing, his ability to draw an optic nerve. But unfortunately, it's not for everybody. So we need this to be more democrat with the knowledge of the optic nerve, and everybody was. He was happy because it was a compliment. Everybody was happy because it makes sense being there, looking for this, watching these lectures, and you fix everything. And it was more than 20 years ago. And my question is, with all this new technology that's advancing every day, do you have an impression that people are getting less blind with this technology? Did are we changing something, or is just uh, uh, um, is just a different way to see that? But we are looking for we should look for different things. For example, we know that who gonna be blind with glaucoma is who starts with the disease. We start with the diagnosis with a very advanced disease, and we are looking very hard to find the glaucoma at the beginning. Are we doing anything wrong, or do you think that this new technologies is making better, or what's your impression?
So, Augusto, as you well know, I think one of the most important papers that has been written in glaucoma was written by my mentor, Morton Grant, a paper entitled Why People Go Blind from Glaucoma. And he studied this question. And some of the main reasons were what you were saying. Number one, failure to recognize it at a very early stage, because people who had more advanced disease, more advanced damage, I should say, were more likely to continue. They're more difficult. The more damage you have, the harder it is to control. And the other thing, of course, something that we're all very much aware of is compliance with medical therapy. So, to answer your question, I don't know the answer. I don't know if there's been a study done to look and see if a smaller percentage of glaucoma patients are going blind today than were, say, 30 years ago. But I sort of have the impression that if there is a difference, it's not a big difference. I think we still have a long ways to go. And I think the big issues that we're still facing are how to find these patients when they're very early, not when they have advanced disease, but at the very earliest stage of their disease. And that can be very difficult, as all of us know. And then, of course, the other thing is getting patients to comply with medical therapy. Although I think maybe a little later, Augusto, when maybe we talk about treatment, we can talk about new paradigms that may de-emphasize medical therapy compared to what it used to be.
Mm-hmm. Thank you. Now I'm going to open for my colleagues to make questions. Who would like to start?
I may start.
You want me? Yeah.
Good evening, Shoots. You don't remember me probably, but we met in 1997. I was but a resident. I was in charge of taking you from the airport and to the airport from the National Glaucoma Society meeting. And we came talking, and I already read your book, which I found so fantastic. I have it to today. It's the best glaucoma book I've ever read. And we came talking in my car, and I came thinking, how can somebody so sapient, so wise, so experienced, be so humble to talk like equals with me, a mere resident, and since then, I'm a very great fan of yours. But my question comes from exactly the treatment part of the glaucoma disease. In 2008, you have published a review on normal tensile glaucoma. And in your conclusions, you recognize, of course, the importance of even in these patients controlling the IOP.
Yes.
But as we know today, these patients have other factors that are not IOP dependent. And you advise researchers to pursue of intervening directly in the optic nerve to treat directly in the optic, which treat directly the optic nerve to avoid blindness for these patients, or to make vision easier for them to have a better quality of life. My question is, do you think that from 2008 until 2020, how much have we progressed, if we progressed? And if we didn't progress enough, what is your best guess to where we should pursue to find these answers?
Well, Marcelo, first of all, I want to say, yes, I do remember you distinctly because, and you're being very kind because you left out one thing about our trip from the airport. You know, I had been up all night flying and I was pretty sleepy. And much to my embarrassment, I fell asleep while you and I were driving into Sao Paulo. but you were very kind about that. And you were very kind to come get me. And I have fond memories of our time together. I also remember all those little motorbikes flying around us. Do you still have all those in Brazil?
It gets
Oh,
worse.
yeah.
It's getting worse.
It's getting worse.
So, very good question. Normal tension glaucoma is a very important component of the patients we treat. And I must say this, I don't see normal tension glaucoma and high pressure glaucoma as two distinct separate entities. I think there's a kind of a spectrum, a continuum, that they kind of flow from one to the other. Although it is true that those patients with the lower pressures do maybe have certain differences in the appearance of their nerve and in the appearance of their visual field. And what you said, Marcella, is very true, that some of these patients do respond well to lowering of the pressure, which is fortunate because that is still the only thing we have right now. Augusto, were you at Yale when we were doing the memantine study?
No, actually, I was back in São Paulo, and I was in charge of the memantine study in São Paulo.
Ah,
The
so
study did not work.
we had great hopes for that because it looked very promising in the animal studies, and we thought, well, now here may be our first opportunity to treat the optic nerve with a pressure-independent medication, which we need very much. But as we all know, that it didn't turn out to be what we had hoped it would be. And to answer your question, from 2008 to today, 12 years later, we still don't have a pressure-independent medication. I think we have some things possibly in the pipeline by virtue of study of the optic nerve head in glaucoma. We're learning more about the disease and where we might find an IOP independent drug. But at the moment, as you know as well as I, the best we can do is to keep the pressure as low as we can. And hopefully that'll change one of these days.
Mauro.
And do you notice?
Oh,
And do you notice when you examine these patients, just looking at them clinically, that they are more pressure dependent or more pressure independent?
Well, I do think there are some subtle differences in the appearance of the optic nerve head and in the visual field in a person with a low pressure as opposed to a very high pressure. As you know as well as I, they tend to be a little bit more localized neural rim damage. The visual field tends to be a little closer to fixation early on. Those are some of the things. But again, it's such a spectrum, a continuum of disease that it's very hard to look at the nerve or the field and say, oh, for sure this is one and this is the other, because there's a lot of overlapping.
Thank you.
Mauro.
Good night, Dr. Shields.
Hi.
We never met before. I only know you by your writing, right? Which is already wonderful. So I'm very glad to be here speaking to you.
Well,
I'm not Carolina, my name is wrong here, but that's okay. I'm Mauro, and
yeah,
very nice to meet you here.
Right.
People are sending messages to me, so.
I know Carolina is much better looking than you.
Yeah, I agree that. Yeah, that's certainly right. Okay, I have to thank you for agreeing to participate in this interview. It's both a pleasure and an honor to be here with you. I'll try to contextualize this next question in a meeting I had with Bob Weinreb 10 years ago during my fellowship with Dr. Medeiros, okay? So, as you know, Dr. Weinreb, he pulled the old Socratic dialectic on all of us. So he asked a very simple question: what is glaucoma? And he started from the first year resident to the attending physician, and he managed to destroy every single one of them, like showing flaws in their answers, like, oh, that's wrong, what's the characteristics, and so on. So I ask you this rather epistemological question: do we know what glaucoma really is, or where can we find this answer?
You know, I recently wrote a paper for an Australian journal, and I reviewed the history of our understanding of glaucoma. And glaucoma has been probably one of the most misunderstood diseases, group of disease processes of any in the spectrum of medicine. In fact, the name glaucoma is a misnomer because, as you know, in the Latin, it refers to a kind of the bluish green color of seawater. Now, this was back in over 2,000 years ago. And undoubtedly, what the ancient doctors were seeing was not glaucoma, it was cataracts. But for some reason, they stuck the name glaucoma onto this condition that today we call glaucoma. But then later on, another name comes along, and this is the Latin word cataracta, which means waterfall, the falling down of water. Well, that would have been a much better name for glaucoma, because it deals with the movement of water, which is what glaucoma is. And glaucoma really refers to the clouding of the lens of the eye in the ancient days. So even the name glaucoma is totally wrong. What you and I should be treating should probably be called cataracts, but it's not. It got just reversed, just backwards. So anyway, we're stuck with the word glaucoma. Well, then many centuries passed, and we finally learned that this thing we're calling glaucoma, a lot of the people have high pressure. Now that was learned back in the 10th century in the Persian literature, it appears. But it really wasn't until about the 19th century that it became clear that glaucoma was associated with elevated pressure in the eye. And so that was the definition of glaucoma, high pressure in the eye. And if you look at some of the glaucoma textbooks, one of the leading textbooks of the first half of the 20th century was by Saul Sugar. And in his textbook called The Glaucomas, he defines glaucoma. And he says, the word glaucoma is simply a synonym for elevated pressure and should be understood as such. And it really wasn't until the late 60s, early 70s that we began to realize, well, that's not exactly right, because some patients who are blind from glaucoma, they never have high pressure at all. And other patients have a high pressure and they never get glaucomatous damage. So we began to realize that that it was really the common denominator was the optic nerve. And it was actually Mike Van Buskirk and George Schiaffi who came up with the definition of glaucoma, which still, and I think Bob Weinreb would probably agree with this, that the definition that's most accepted today is the glaucomas as a large group of diseases have as their common denominator a characteristic damage to the optic nerve, which is followed, if not treated, by a characteristic and progressive loss of the visual field, which may be associated with elevated pressure. Something like that.
Yeah.
Yeah.
Yeah. Thank you. Thanks very much, Dr.
Tiago, microphone. Okay.
So, Dr. Schultz, it's a pleasure. It's a great pleasure to meet you. I was really looking forward to this webinar tonight. Although I had a pleasure to attend to many of your lectures, international meetings, and I know your book by heart. We never met before, unfortunately. So my question is a more general one. It's related to teaching this new generation. Most of us here, we are professors and we're preceptors. And we have seen significant and very fast changes in the relationship between professors and residents and fellows, and even in the physician-patient relationship in the last 10 or 15 years. I think it's really fast changes have occurred. And technology, internet, social media, they might have some positive changes, but at least in my opinion, they also have negative aspects. And I know we certainly have many doctors in training and fellows in the audience tonight. So my question is, what would be your key message, your advice, your key advice for these fellows, for these residents that are to begin their career? Your message or advice in terms of what they should do.
Well, that's a extremely timely question, because with all the new technology we have, including artificial intelligence, we have more and more of an opportunity to sort of circumvent. We may spend more time looking at the image analysis or the field or the computer generated information. And this past year of this COVID pandemic, I think has even accelerated that because it has moved us further into telemedicine. Now, there's nothing wrong with any of that. Telemedicine certainly has a place. It has been helpful during this pandemic, but I share your concern that we may be losing what I would call the art of medicine. And I think the art of medicine will always be important. No matter how much technology we have, the doctor-patient relationship, especially in glaucoma, is critical. And you know this as well as I do, that the relationship you develop with your glaucoma patients is critical to preserving their sight, that they develop confidence in you and what you advise them so that they will comply with what you're recommending. And I think going back to what we were talking about earlier, that is Dr. Spaeth's comment about the importance of looking at the optic nerve and making, I think the value of making attempting to make a drawing of the optic nerve at least has the benefit of forcing us to really look carefully at the nerve, carefully enough that we can translate what we see to the best of our ability onto paper or to the computer or whatever we're using. So I think that what we probably should be teaching our students and residents and fellows is that, well, yes, we should embrace all the new technology, make the most of what we're given in terms of image analysis, the latest in visual field technology, the ability to computer document progression of field and things of this nature, but not at the expense of losing the doctor-patient relationship, because I think that will always be an important part of us practicing the art of medicine.
Thank you. Thank you. I totally agree with you. Thank you. Thank you for your answer.
Thank you.
Carolina? The real Carolina?
Yes. So, Dr.
Bye,
Hugh.
Carolina.
So I'm Carolina.
Yeah, much better.
Thank you to accept this invitation. It's a great pleasure and great honor to having you and to having the chance to interview you. So regarding the therapeutics in glaucoma, my question to you is, what do you think will be our future directions? So just put in context, we know, as we discussed before, we know that the hypotensive medication sometimes is not enough for many types of glaucoma, or even for the open angle glaucoma. We see progression even with low IOP. So do you think in the future we will have space for example, neuroprotection, as we discussed a little bit, or for example, alternative medicines such as mindfulness or different medicine to treat this type of patients?
You just said the word mindfulness.
Yes.
Mindfulness. You know, I've got to tell you, Carolina, my wife is very much into mindfulness and contemplative types of thought. and she's always talking with me about consciousness and mindfulness. Um, and I've got to tell you, I don't know much about it. I do think that we certainly need better ways to treat our patients. We talked earlier about the fact that unfortunately we still don't have an effective pressure independent treatment for the glaucomatous optic neuropathy. And hopefully we will have that in the future. I do think this. I do think that our paradigm for treating our glaucoma patient is going to change. In fact, I think it's changing as we speak because, well, for the most part, we've had medications to lower the pressure and we've had surgery. More recently, we have laser. But the main glaucoma operation that we've used for over 100 years really hasn't changed that much. The trabeculectomy we do today, while it is probably the most effective way to lower the pressure as compared to the newer procedures, the MIGS, minimally or microinvasive glaucoma surgery, has a lot of potential complications. And as a result of that, and you know this as well as I do, most glaucoma specialists are reluctant to go to surgery early on because of the risks involved. And so we go to medication. And yet we know that medication has a lot of disadvantages, not only side effects, but lack of compliance. So I think that these new operations, these MIGs, do have a place, but as you and I both know, they don't lower the pressure quite as much as trabeculectomy, or even maybe as your standard tube surgery. But they are safer. They don't have the complications. So it may be that in the future, if we can have better ways to diagnose our patients early, so we can detect their glaucoma when it's at a very early stage, when a modest pressure reduction would be sufficient to control them, why then we might be wanting to recommend one of the MIGS operations at an earlier stage, maybe even as the initial treatment. And of course, that would have the advantage of circumventing the compliance issue. And I think we're starting to see that now. I'd be interested to know what you're doing in Brazil with laser trabeculoplasty, SLT, or whatever you're using now. You know, a lot of glaucoma specialists in the US are actually going to laser first as initial treatment. And that may provide adequate pressure control for 5, maybe 10 years. And it can be repeated. We did a study at Yale to show that you can repeat laser trabeculoplasty. But the day may come when the laser no longer is effective. And then you might either go to one of the MIGs, or you might try one of your drops. And if it has a very profound effect, and you're confident that it's preventing progression, you might continue with the medication. If not, you might go straight into surgery, hopefully at a time when the glaucoma is still in an early stage. So I can kind of see that as a paradigm shift. Laser trabeculoplasty, when that's no longer effective, maybe one medication. If that's not effective, then going on to a MIGS. Um, and that may be much better way to treat our patients than we do now by starting out with medications and then just kind of watching them lose vision until we finally say, whoops, we better do something more. But by then we need a stronger operation like trabeculectomy or tube surgery. But as far as mindfulness is concerned, I wish you would tell me how that works.
We are discussing this, Bruce, because we invite Professor Dada from India. He wrote a randomized clinical trial on mindfulness for glaucoma. And actually, the mindfulness in this randomized clinical trial lowers the IOP much better than some medications and even for MIGS. The pressure goes from 19 to 13. So people are excited about that because it's something that you can add um, to the treatment more than just giving drugs. And people are usually asking us what else we can do besides just using the drops. So now we can say, oh, you can do mindfulness. That's why.
Uh,
Well, I find that very interesting because, as I told you, my wife is really into this. Uh, and she and I have been reading a book. It's really a book about meditation, but it it's talking about how they're doing, and I'm not sure what the technology is, whether it's MRIs, PET scans, but they do have some kind of brain scan where they can monitor changes in the brain pattern with no other intervention other than meditation, which I guess is another word for mindfulness or uh, putting your mind at ease or whatever mindfulness means. But there is scientific support for the fact that you can literally alter your brain by meditation or similar types of uh, mind exercises. and, and I've got to tell you, I just told you more than I know about it, but it's an exciting possibility, and I would not reject it by any means.
Yes, and moreover, Dr. Schultz, this meditation article was published in Journal of Glaucoma. It is a clinical trial very well conducted, so that's why we were so excited. And in addition, my study, my postdoc research was related with MRI. So that's why I asked you about neuroprotection, because every time when I present my results from my PhD, my postdoc research, we have a lot of discussions about neuroprotection because many people are very super fan of neuroprotection and many people are totally against this type of medications. So it's hard to decide now, as you said. Now we don't know, but maybe in the future we have another option.
Yes, yes. Well, I hope you will continue your research because I think it's very exciting, and I'm looking forward to telling my wife what I just learned from you.
Thank you, Dr.
I remember when I was your fellow, you moved from different rooms, I think 3 or 4 rooms. And while you're finished, your one patient was still there and you go to the other room. And you stay the whole day like this without eating. And I said, oh, he never eats. It's something strange. He never eats. And then after like 6 months there, we are starving because we do not eat. We realized that whenever you leave a room and leave us in the room, you just eat something, a snack, the whole day. You remember that?
That's a very bad practice, yes. And I still kind of do that now. I usually don't eat lunch.
There's a person that wanna ask you some question. Let me move him here. Let me see. Consegui. There he is. Vital wanna ask some question.
Hi, Dr. Schultz. How are you?
Hey, good to see you.
Good to see you. I had to ask for this opportunity here to say how much I am thankful to you. First of all, I was like Marcelo, your shadow. Shadow is what you do when you take a speaker, an international speaker everywhere in Brazil. And I did that when you first came here, I think in 87 or 88. And you were kind enough to invite me to go down to Duke. And I did that as a second year resident. And as a second year resident, I used to have a very childish face by that time. Not now, but this gray hair. But by that time, I was kind of childish. And I was seeing patients with you. And we were examining a lady, probably around in her 60s, and she looked at me and said, "There's no way he's a medical student. He's not going to be examining me today." And your reaction was something that impressed me, and I still tell this story to everyone I know. You looked at her and said, have we lost him?
I think so.
Oh, he's back.
What? Just a minute.
Hi, Bruce.
Yeah.
Your microphone's on.
I think that no.
Your microphone.
Just a minute. Let me put this mic on. You have to turn on your microphone. Okay. You're not green anymore.
I'm so pleased I got my color back.
Yeah. Now, did you listen to the story? To what point did you get? Did you get to the point where I was seeing a patient with you at Duke?
No.
Oh, sorry. So let me.
I think we left off where you were shadowing.
Okay. So I was a shadow just like Marcelo. You invited me to visit Duke as a second year resident. And there I go to visit Duke. Fantastic campus, by the way.
Yeah.
And then, I was seeing patients with you, a lady in her 60s. She looked at me and said, "There's no way you're going to examine me because you're a medical student." And what you said to her impressed me till today. You looked at her very seriously and said, "Listen, this is a learning institution, a teaching institution. Dr. Costa is a resident coming from Brazil. Now, if you don't want to be examined by a resident who comes from a different country, I can give you a list of 3 different doctors that you can choose from and follow your glaucoma with these doctors." She rapidly said, "No, I can. He can examine me. Go ahead, examine me." So this is just one story that I wanted everybody to know. This explains part of what you are. I'm really. I think you are a blessed individual, a blessed soul. I don't know anybody else like you.
Well,
You
you're
are
very
the kindest person that I've ever met in my life. And you were so kind to have me to come back to Yale to lecture. Actually, Augusto and Mario were there. And that was very, very emotional for me. And I still keep this. You might remember this.
Oh yes, Maurice.
You took me to Morris to have dinner. And I still keep this and have every day, every single morning, my coffee in this mug.
Wow.
So gratitude is the only word that I can express whenever I talk to you. Thank you so much.
Well, bless your heart. I tell you, you are so kind. I tell you, I do feel blessed myself to have friends like you and Augusto and Maria and now more friends we met tonight.
Yeah.
Thank you.
I asked some friends to
Thanks, Natal.
Guilherme is here also, and Maria. And well, it's more than 1 hour. I would like to do Maria, Guilherme, Marcelo, Carolina, or even Vital. Do you want to have some? We're gonna finish now. Did someone have some questions to finish? You have to open your microphone if you have some question, Guilherme or Maria.
Is it possible for
Dr.
Maria
Shields?
to come on? Ah, there you are.
Hi, I missed you so much.
Oh, I miss you. We have good memories.
Mhm.
I was so happy to see that picture of us at Arvo, I think it was.
Arvo.
And I
I just
cannot
want,
believe you got a 13-year-old daughter.
I'm getting
Oh,
old. I'm getting
aren't we
old, you
all?
know. I just want this opportunity to thank you for being my second father at Yale. You treat me as your own daughter, like I said before. And I won't forget this. It was very, very important for me. And everything you did for me in my 2 years that I spent there, not just treat glaucoma, but also how to treat the patients with kindness and love. So you are an example for me by life and everything. And I can say that you were a second father for me. You are a
That
second
is
father for
so
me.
sweet. And
Yeah.
I can tell you in all honesty, having you and Augusto there at Yale when we were all together, it was just as good for me, if not better, than it was for you. I loved it and will always have the happiest memories of those times.
Me too. I think my opportunity there was the best opportunity I've ever had
Well,
in my
thank
life.
you.
Thank you
Thank
for everything.
you for saying that.
Hi, Dr. Schultz. This is
Hey,
Gilly.
how's it going?
Good. How to see you again.
Yeah, good to see you. You got a little more facial hair than the last time I saw you.
Yeah, a little bit more. Good to see you again, and I'd like to thank you. You taught me most of the things that I know about glaucoma, and I think one of the most important things in my career that the best way of getting the best results are treating people well. And like Dr. Costa just said, I think you are the kindest people, the kindest person, and thank you very much for everything.
Well, thank you, Gilly. So good to see you again.
Good to see you.
Something important, and I have to agree with Vital, and Maria and Guilherme has this same experiences. When we finish the seeing our patients, you make us took all the charts and discuss every patient, and sometimes you make us feel so comfortable, and we start asking, why don't you do that? And you just say, oh, this is a good idea, and you just change your mind because one of your fellows make an observation that for you makes sense. This is not a small thing. This is a huge thing. And then I was going back to my house there in Halve Street, 100 Halve Street, and wondering, he just paid attention of my observation and change the way he was treating because it makes sense. it's unbelievable to have this kind of behavior of some of our colleagues that we have now, much younger than you are, with the lack of how to say that immunity that you have, and this is amazing. This is how to teach you. If you don't remember something, say I can remember that. If you do not, if you know, if you can change your mind, you just change your mind. It's no problem about it. So I was always impressed the way you just listen to everybody. You not just listen to your patient. You don't know, you learn from your patient. I believe that. I really don't think that you learn from your fellows, but you listen to your fellows, and you teach very well. And I think this is very important. I think that everybody that is working with fellows have to learn this lesson. There's no problem to listen and to change your mind and argue and see that something makes sense, because you always learn with that. This is the way I remember our discussion after a day in the seeing patients, is the way you listen, the way you describe, and you discuss every patient, even the one that's well treated with timolol. There's nothing to do there. You discuss this patient. You do not miss anyone till the end of the day. You see it every. Imagine that you take all. Shields took all the patients, all the charts, and discuss every patient with us. This is something that I learned a lot. I wish I could be like you, but I'll never be. But I try to take some small things to be with my residents.
Well, you know, Augusto, I always have said that we learn from each other. And I would have to disagree with one thing you said, and that is I did learn from you and from Maria and from Gilly and all. I mean, we learn from each other. And I think that's the beauty of medicine. And it never, it never stops. I guess that's why they call it the practice of medicine, because you never stop learning. And if you close your mind and think you know it all, you're going to miss so much. So I learned a lot from you, and and I have no doubt that you're carrying on the tradition of excellent teaching.
Well, any more questions? Any last word from anybody? Okay. Well, Bruce, thank you again. Sorry about the time that I understand that now when you send a invitation by Zoom, there's a standard time that you have to change. And the first invitation was with this mistake. But well,
All worked out.
everything is okay, and we were able to do this interview. And the idea of the interview is to have everybody, is to put a face in the famous book, and a voice in the book. It's not just a well-written book. It's a book written for the most special glaucoma specialist that that we ever seen. Thank you very much for that. Have a good night. And
Well, Augusto,
see you soon
I
in
want to thank
person.
you and all your colleagues. I've enjoyed this so much, and thank you for the opportunity to see all of you again. And I wish each one of you the very best. Hope our paths will cross again one day when the pandemic is over.
Sure. And it's
Thank
good.
you.
It's good not.
Thank you.
It's good seeing that you're not green. That you help.
Yeah, I'm glad I'm
The same. You're the same. You didn't change.
Well, it's good to see all of you, and I wish you all the very best.
Okay.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye.